Thanks.
Great. Thank you, Steve. Good morning, everybody. Thank you for joining. I'm Chau. I'm a breast medical oncologist at Memorial Sloan Kettering, and I'm also the medical director at one of our sites of Memorial Sloan. I've been in practice for about 20 years, and my research focus has been on designing novel therapy in early stage breast cancer as well as HER2 positive breast cancer with a focus on cardiotoxicity. So it's my pleasure to speak on cardiac monitoring when treating breast cancer patients with cardiotoxic drugs. Now, this will really be pertaining to LVEF monitoring for this particular topic for patients on anthracyclines and anti-HER2. So it's limited to this particular topic. So, the check-ins for this morning will be the cardiotoxicity from anthracyclines and anti-HER2 treatment from clinical trials, as well as from claims-based data. And we'll run through some of the current national guidelines on how patients are being monitored or should be monitored, and maybe some guidance on LVEF monitoring during the period COVID era. Certainly, we're in an unusual time, and we've had challenges in getting monitoring done on a timely basis for various reasons. So at Memorial Sloan Kettering, we came up with some guidance. Certainly, it's not bylaws, but just some guidance. So here we go. So I'll start with cardiotoxicity from anthracyclines and anti-HER2 therapy. What are some of the questions? And so we'll go through them. What is the incidence of New York Heart Association Class 3 for heart failure or grade 3 for left ventricular systolic dysfunction in patients getting treatments with anthracycline anti-HER2 in breast cancer, such as an AC followed by taxane, trastuzumab, pertuzumab, or non-anthracycline anti-HER2 treatments such as paclitaxel, trastuzumab, such as TH or THP, which with pertuzumab, or docetaxel, carboplatin, trastuzumab, and so on with pertuzumab as the second anti-HER2 agent. And what is it with just anthracycline-based treatments such as ACT? And what is the incidence of LVEF decline after AC in patients getting sequential AC followed by taxane anti-HER2? And when do we monitor after AC? And what is that frequency of monitoring? And certainly that's important to discuss, especially in this time. And does serial monitoring really lead to better cardiac outcomes? So we'll discuss some of that data. So let's start out with discussing some of the older data. As we know, trastuzumab was approved in 1998 combined with chemotherapy for the treatment of metastatic HER2-positive breast cancer. And from 1998 onward, there were 4 large trials that were launched as listed here. They are HERA, B31, and 9831, and BCIRG 006. And these trials were set out to ask the question whether a drug like trastuzumab added to chemotherapy was going to improve efficacy. And one of the endpoints was to look for cardiac toxicity of trastuzumab combined with chemotherapy because of what we learned from the pivotal study in the metastatic setting that trastuzumab added to anthracycline augmented heart failure, but much less so when seen with non-anthracycline. And so in the earlier years, the median follow-up of about 2 to 5 years, as noted here, the rates of NYHA class 3 for heart failure with an anthracycline followed by anti-HER2 was upwards of 4%. It was about 2 to 4% with an AC followed by TH regimen. But as noted here, BCRG 06 conducted the trial where one arm was a non-anthracycline that was TCH. And we saw here that the heart failure rate was about 0.4%. Now, with much longer follow-up later, with the median follow-up about 10 years, as we see here in the box in red, that the rates of heart failure were static. So most of the events happened during therapy and hardly happened afterwards. But I do want to point out that these patients had serial LVEF monitoring. So we were able to capture what we call asymptomatic EF decline as listed here, meaning EF reduction to less than 10% to greater 10% reduction to less than normal limit to normal at the time. And it was upwards of about 18%. So almost 20% of patients had asymptomatic decline, not necessarily associated with heart failure, but led to was a holding anti-HER2 drug at the time 20 years ago. As we note here to the far right, that upwards of almost 20% of patients had their drugs held. Some of them had their drugs stopped completely. Some were able to return to treatment and so on. But we learn a lot about these trials in that heart failure happened mostly during therapy and not afterwards. So what about some of the more modern therapies? So from 1998 onward, we conducted these trials. 2005, the data were reported at ASCO. 2006, trastuzumab adjuvant chemotherapy were approved in early-stage breast cancer treatment for high-risk patients. But at that time, we started to look at, well, what about the patients with lower risk disease, for example, node-negative, HER2-positive breast cancer? Can they get a non-anthracycline-based treatment? So that led to the conduct of the APT trial, that's adjuvant paclitaxel trastuzumab, with the treatment we say TH, that's paclitaxel trastuzumab, avoiding anthracycline. And the majority of the patients had basically tumor size of 2 centimeter and under, and they were node negative for the most part. And we gave TH, and the primary endpoint was disease-free survival. This was a positive trial. One of the endpoints was to look for cardiac toxicity, as noted here, that the rate of heart failure, symptomatic heart failure, or grade 3-4, left ventricular systolic dysfunction was less than 1%, so it was 0.5%, and that is consistent with what we saw with the older trial of BCRG 006 with TCH, that it was also less than 1%, 0.4%. So without the anthracycline, it was well under 1%. There was another trial that was conducted within US Oncology that was docetaxel cyclophosphamide trastuzumab, TH-like regimen, looking at the effectiveness of this regimen. And they showed that the heart failure rate was very similar. It was 0.4%. So good news here that in patients getting non-anthracycline treatment, that the incidence of symptomatic heart failure was well under 1%. And we also monitored these patients roughly every 3 months during treatment, and we saw that the discontinuation of trastuzumab due to cardiac toxicity, mostly due to asymptomatic decline, was low. It was 3% or less, unlike the trials with anthracycline, anti-HER2, the discontinuation rate varied, but it was upwards of almost 18%. So good news, again, without the anthracycline, risk of cardiac toxicity was low. And some of the more modern trials conducted in the neoadjuvant space, Neosphere up top was a trial that looked at dual antibody therapy, that's H&P, that's trastuzumab, pertuzumab with the taxane docetaxel, compared to 3 other arms. And it really showed that dual antibody therapy with a taxane led to an improvement in PCR, which is pathologic complete response, which led to the approval of pertuzumab in the neoadjuvant setting for patients with high-risk disease, meaning stage 2, 3. And cardiac monitoring was conducted throughout, and the data were captured, as you see here on the right, that without the anthracycline, here again, the rate of heart failure was well under 1%. It was 0.9% in this trial. Around the same time, another neoadjuvant study was done, the Trifina study, and in this trial, patients were randomized to one of 3 treatments. One was TCHP, the other 2 were FEC with concurrent trastuzumab, pertuzumab, followed by taxane HP. The third was FEC sequentially followed by taxane HP. And the bottom line is all 3 arms led to very similar pathologic complete response with the dual antibody therapy. That PCR rate was about 60%. But importantly, to the far right, when we look at the rate of asymptomatic heart failure for the TCHP, the non-anthracycline, again, it was well under 1%. It was 0% in this study. This is during the neoadjuvant time period. But for a regimen with an anthracycline such as FEC followed by docehp, which is similar to the American ACTHP, heart failure was almost 3%. So it's certainly consistent with what we've seen with ACTH, and we saw that pertuzumab didn't really increase that rate of heart failure significantly. And thirdly, down the bottom is the Berenice trial. We did this for the FDA at the time when pertuzumab was approved in the neoadjuvant space to look at the American regimen that's dose dense AC followed by weekly paclitaxel HP to look for cardiac toxicity with dose dense AC. And we also looked at FEC followed by dose CHP again. This was an international trial. And we saw that in terms of cardiac toxicity, in terms of symptomatic heart failure, with an ACTHP regimen, it was somewhere around 1.5%. So again, in line with the historical data with ACTH in that, 1 to 4%. Let's see, trying to advance my slides.
Chau.
Yes.
Chau, this is Dan Lenahan. Thank you so much for doing your presentation. And as always, you're covering a tremendous amount of ground in a short period of time, basically, because these trials are complex. But this slide in particular, it seems pretty important. If you just look at this slide right here, the first one, the neosphere, the pathologic complete response was lower in general than the other ones.
There's a reason for that. Because it was a shorter duration of treatment. The neoadjuvant treatment is 3 months in neosphere, and in Trifina it was 6 months. It was longer because they gave the anthracycline afterwards. It was dose HP surgery, and then they had their FEC afterwards. So they didn't get the full 6 months, just 3 months. So the PCR rate was 46% in this one compared to the control of taxane H, which was 29. So it was better, but we can't compare neosphere against Trifina because Trifina gave the full regimen for 6 months. So more therapy, longer time, better PCR that is expected and consistent with Berenice, where patients get it for about 5 to 6 months, 60% PCR. So,
my other point there was, if you just, without knowing the detail that you just explained, if you also looked at those that contained anthracycline, tended to have a better PCR, and then, of course, once you start including anthracycline, then the rate of LV dysfunction is going to go up a little bit.
That's right. I'd have to say Trifina kind of showed that the anthracyclines probably didn't matter as much because TCH, you saw that the PCR was 66%, FEC, HP, or FEC followed by HP, was around that 60%. So the anthracyclines didn't matter as much. And recently, TRAIN-2 was reported showing similar data that without the anthracycline, if you have double antibody therapy, that sort of levels the playing ground. So there's sort of a shift in giving less anthracycline worldwide, I think, because of these data that are emerging.
Yeah, so I'm not a breast oncologist, so I don't know the subtleties there, but obviously I trust what you're saying. But I think that certainly in countries that don't have, a very robust healthcare system, they're not going to be able to use dual antibodies for extended period of time. So they're much more likely to use anthracycline.
Agree. I agree with you 100%. We're talking about, therapy that really is more relevant for the developed world. You're absolutely right. Anthracyclines are very important still, an active chemotherapy, active in, HER2 positive, high-risk breast cancer, and should be used. And the older data from 20 years ago with ACTH leading to significant improvement in disease-free and overall survival kind of put Herceptin and trastuzumab on the map with anthracyclines in curing patients with breast cancer. So that is still a regimen that's standard today, but for node-positive, higher risk patients, we're adding the pertuzumab on. So in the modern era, we're using ACTHP or TCHP for those who wish not to use anthracycline. But you see less cardiac toxicity with non-anthracycline, and it's just seen over and over with a non-anthracycline, which is good news. Let me continue on. I just wanted to, sorry. Okay. All right.
No,
Now,
I wasn't trying to hang you up there necessarily, but that's such an important issue, at least from our perspective. I mean, I don't understand all the subtleties about how many months before treatment and how many months
sure.
after treatment and all that. Just
Right.
whether or not anthracyclines are part of the equation is usually the most important thing.
Yes, I agree with you. I mean, when we give neoadjuvant therapy, our chemo regimen is about 5 to 6 months from start to finish. The anti-HER2 is a year, so that's sort of embedded in during the taxane phase. So we today give the chemotherapy from start to finish pre-op. We don't split it in half. We don't give the taxane first, surgery, and anthracycline. We just give the whole thing. So it's 5 to 6. So we are seeing the PCR of 60%. So that's the current practice. So I'm showing you here metastatic trials. You know, we just went through early stage in the metastatic setting. So Cleopatra was a very important study that launched pertuzumab on the map for patients with stage 4 breast cancer for a very long time. Paclitaxel, trastuzumab, docetaxel, trastuzumab, taxane trastuzumab for treatment of metastatic disease was the standard for about a decade and a half until pertuzumab was added to the mix, meaning taxane HP, TH, or THP. So 2 against 1, 2 anti-HER2 against 1. And what Cleopatra showed was that 2 was better than 1, meaning THP was better than TH. But the good news here to the far right is that heart failure wasn't that bad. It was 1%. It was patients were monitored every 3 months and so on. The asymptomatic decline was about 60%, but the heart failure was 1%. That's really great. MSK, we did our own study with our taxane, and it was 0%. In our particular study, it was small. But point being is that we saw symptomatic heart failure of 1% or less. Now, mind you, these are trial patients, so they were healthier patients with healthy hearts. So we have to keep that in mind. Okay, so in summary, in terms of the history of anthracyclines and anti-HER2, to the far right, HER2 positive, what I listed here is rates of symptomatic heart failure for a regimen like ACTH. It's 2 to 4%. In the adjuvant study where pertuzumab was added, so 2 antibodies in affinity, it was 0.8%, so hovering around that 1%. TCH, it's less than 1%. TH, less than 1%. TCH, again, less than 1%. So without an anthracycline, it's thematic. You're seeing the 1% or less. In the metastatic space, docetaxel HB, again, that 1%. So non-anthracycline, anti-HER2, you get that 1% or less. With anthracycline, it goes upwards to 4%. But we have to keep in mind that when we're treating patients with early stage breast cancer, cure is always the goal. So it's decisions we make in the clinic, who should get anthracycline or not, but that when they do, we definitely want to monitor the heart. To the left, for the HER2 negative, we still use regimens like AC, ACT. There's several different versions of them, but the bottom line, these patients get their LVEF monitoring at baseline. And in terms of symptomatic heart failure from trials, it's about 1 to 3% with just the anthracyclines and non-anti-HER2. So it's just anthracyclines. So that's the background. Now, just want to show you this. Everybody knows this original trials, B31, 9831, patients getting ACTH. They were monitored every 3 months, as noted here. So this was what was adopted within the FDA as far as guidance on how often patients should be monitored when they're on trastuzumab-based treatment. And just something to note, in these trials, when patients were getting their AC, they had their baseline EF, and they had to have their EF checked again post-AC. And these rates that I show here, these are rates of EF decline post-AC. It was something like 6% after AC before getting TH on the B31 and 9831 trial. In our own little study, those stands ACTH, we didn't see any decline, but again, we selected patients with healthy hearts. As you noted here, they entered the trial with higher ejection fraction at MSK of 55%. So I do think that mattered because we pre-selected patients with healthy hearts, so we didn't see patients with EF decline post-AC. But in the real world, what is that number when we monitor patients post-AC? It's probably the same at best, or possibly worse, because in the real world, we're treating patients who have comorbidities, et cetera. But it's important to monitor our patients when they're getting cardiotoxic drugs. So claims-based data, I think we've seen this slide many times. Certainly, the data show that the cardiac event rates are higher. There are 3 trials that I show here. The first one in 45,000 patients, older population, mean age of 76 years of age, and they looked at patients who had trastuzumab alone or anthracycline trastuzumab, and this is a culmination of rates of heart failure and or cardiomyopathy. So it appear higher than what the trials are showing. With trastuzumab, it's about 32%, anthracycline followed by trast about 42%, and so it appeared higher. And there were 2 other data sets that showed sort of similar trends. So certainly, what do we take away from this? I mean, there are caveats with claims-based data because of a lack of stringent adjudication, but the truth is probably somewhere in between what we see in the trial setting and claims-based as far as real-world experience.
So Chau, I
yes.
would say on that part right there, so everything you said is totally on the money, but part of it is the definition of symptomatic heart failure in a trial is based on CTC grade 3 or 4, which is pretty severe heart failure. That's symptoms at rest.
Yeah.
And so that's one definition. And then when you look at these claims-based data, like you point out, that the way that they detect heart failure, especially in the first 2 bulleted ones there, that they detected heart failure by any billing code of heart failure. And so if you have a billing code that says heart failure, that could be the reason why you got an echo. So that's not a clinical condition. It's a reason that you ordered the echo. And so it showed up under billing issues. And so I think that, you don't know if you're actually detecting heart failure based on the claims-based data. You know that somewhere in the billing code for that patient was the term heart failure. That's it. And so there's a big distinction between the definition of grade 3 or 4 heart failure versus a billing code that has heart failure in it. Those are 2 dramatically different things. And so in the end, you're probably right that the likely incidence is somewhere in between those 2 numbers.
Yeah. I think that we just will never know for sure, but I think that when we take care of patients in real world, they are sicker than the trial patients. So we are mindful of that, and we're becoming more aware of checking for hypertension and cardiovascular risk factors, that we need to send them to cardiologists at baseline to help us optimize their cardiac care before they start their therapy, rather than just running wild, giving them anti-cancer therapy and not paying attention. And because thank goodness patients are surviving breast cancer, but we have to respect the fact that they're getting cardiotoxic drugs as well. So it's somewhere in between. I agree with you. Okay, so utility of cardiac monitoring, is asymptomatic decline predictive of heart failure? At least in the oncology setting right now, it's still unclear, probably because of the way that trials have been designed so far. Does intervention of cardiac meds improve outcomes? And most likely, yes, but it's still unclear. In the preventive trials, we talked about Prada, Menacor, and others. The patients who came onto the study, they were randomized to cardiac meds or not. And the stories that cardiac meds led to an attenuation of EF decline, which is great, but does that prevent heart failure in the future? The trials were not designed to look at that. But the patients who got into these trials were, for the most part, healthy. They were not patients with high risk features for the most part. So it's hard to know whether cardiac medications for all comers matter. But I think, Dan, you can speak to this. I mean, in the cardiology world, you all are moving forward in conducting trials, embedding cardiac meds in patients who are more at risk, if you will. for events?
Yeah, I mean, I think this, as with many things that you've pointed out today so far, is that there are many viewpoints, and some people are firm believers that that's truly a beneficial approach in virtually all patients, and then other people are, I would wait until I saw some change in LV function before I, initiated therapy. So I think the quote right answer is probably somewhere in between those extremes. But certainly in anybody who's high risk, I would be very likely to give them some form of cardioprotection. And so, but that means that you have to discern what is high risk or not at baseline. You can't just do an EF, and if it's normal, then that person's good to go. I mean, define high risk based on hyperlipidemia, hypertension, previous history, et cetera, et cetera. So there's other factors that have to be looked into.
Sure. And we're going to discuss that, Dan, and you and Sarah wrote the beautiful guidelines for ASCO, and you've identified some high-risk features for us. So we've been using that as our go-to. Third bullet point here is there potential harm in excessive monitoring. What that means is that if we monitor every 3 months, we find asymptomatic decline. Do we just automatically stop therapy because the FDA guidance says you're supposed to stop when there's a ejection decline to a certain point? And could that lead to poor outcomes? And today, there's a strong push to continue treatment in collaboration with our cardiology colleagues to initiate cardioprotective meds. And I will speak even beyond that we should have cardiology see our patients in the beginning rather than wait until we see a decline to help optimize therapy in the beginning. And with all that, to allow us to continue treatment without interruption to optimize both oncologic and cardiac outcomes. Because as patients survive cancer, we still worry about potential cardiovascular cardiac events later. So there's certainly a collaboration. We can talk about this at the end on how far do we go in terms of letting patients continue on therapy, how low is the EF, and so on.
I mean, Chau, you've been one of the leaders in this concept. So I fully and 100% agree that excessive testing is not only unnecessary, it is likely to be harmful. It's certainly more expensive. And so yeah, I'm very much on this same page on this one.
Right. And then we'll need your guidance, Dan, in terms of what's considered appropriate. So let me just keep on going. So, and I'll just run through the national guidelines. You all know this. The FDA, quite stringent, but based on older data, and that is to assess LVEF at baseline and every 3 months during trastuzumab-based treatment, and then every 6 months for 2 years after ending of treatment. This is really more relevant to the patients with early breast cancer when they actually end treatment, as opposed to metastatic, where they continue on their anti-HER2 indefinitely. And bullet number 2 is on when to hold your trastuzumab based on EF decline, as seen here, 60% or greater from baseline, or dropping 10% or greater from baseline to less than lower limit of normal. So these are just old languages, and then resuming when your EF recovers, and discontinuing if it does not recover within 8 weeks, which maybe not the way we practice always today because of our cardiology colleagues helping us to continue meds with cardioprotective meds. In terms of the NCCN, looser language, evaluate LVEF prior to and during treatment, meaning prior to anti-HER2 and during treatment. The optimal frequency of assessment is still not known, and they speak about the FDA language, but really the frequency is still unclear. In ASCO, of course, Dan and Sarah wrote this beautiful guidelines here. Routine surveillance imaging may be offered during treatment in asymptomatic, considered to be at increased risk, and we're going to talk about who those are who are at increased risk. And in these individuals, echo is the surveillance imaging modality of choice, and frequency of surveillance should be determined by healthcare providers based on clinical judgment. So here, Dan, here you wrote this. I try to break it down for simplicity. I hope I did it right. On the left side, patients considered to be at increased risk for cardiac dysfunction, who are getting low dose anthracycline, low dose meaning dox dosing of less than 250 milligrams per meter square, or epi dosing less than 600 milligrams per meter square cumulatively, like a ACT type regimen with at least 2 risk factors, or getting non-anthracycline like a TH with risk factors. And here they are identified: smoking, hypertension, high lipids, diabetes, obesity, older age of 60 plus, compromised EF, 50 to 55, meaning the lowish 50%, history MI, moderate valvular disease. So is that right, Dan? I hope I got it right.
That's beautiful.
Okay.
No problem.
Okay, thank you. And then if patients getting sort of a double hit regimen, meaning an anthracycline and an anti-HER2, regardless of their baseline risk, just getting ACTH-based treatment puts them at a higher risk because they're getting a double hit. But to the right, the patients with unclear risk are those who are getting what I call a single hit, meaning an anthracycline or a traz, not both, an anthracycline or a traz base without risk factors. So simply put, single hit without risk factors. So lower risk or unclear risk. Okay, so put them side by side. So in looking at how to monitor breast cancer patients on an anthracycline-based treatment like ACT, so if they're increased risk, meaning that group that Dan had identified, older age, 2 risk factors, etc., they get their echo baseline, and then during their treatment they get their monitor, and their cardiovascular risk factors should be managed, meaning here we should work with our cardiologists or primary to help manage their hypertension, their diabetes. But as far as echo monitoring per clinician during, it's really left up to the docs. And Dan, I must say, most of us are not doing echoes during AC. We're sufficiently worried enough about their heart. We're not giving anthracycline, but if they really have bad breast cancer and they really need it, it's a good idea to do it, but I'm unclear on when to do it, quite frankly, because if they're getting AC 1, 2, 3, 4, do you do it right after AC 4? Do you do it between number 2 and 3? It's just really unclear. But the wording is left loose here, echo monitoring per clinician. And then after treatment, it's recommended to get their echo within a year after treatment. But for those with the unclear or low risk getting ACT, they just get their baseline echo, and that's just it. For those who are on anti-HER2 therapy, who have increased risk because they're getting a double hit regimen like an anthracycline and anti-HER2, or they're getting their anti-HER2 and they've got risk factors that puts them at high risk, they get their echo baseline, they're getting their serial echo, and at the end, it's recommended they get an echo within a year after they're done. Those with unclear or low risk, meaning they're getting a single hit, meaning just an anti-HER2 without risk factors, they get their echo baseline like TH, but the frequency is unclear here. And I must say, we were involved in the TH trial, and they were monitored almost every 3 months during TH. That's like 4 to 5 echoes during the year. And asymptomatic decline was 3% or less. Heart failure was 0.5. And the people who had heart failure were 2 women out of 400 who had hypertension, diabetes, obesity. They had risk factors already. So a regimen like TH really confers very low risk of cardiotoxicity to patients. The frequency is unclear for this regimen. So with that, now I will do this because there's 30 minutes. I don't want to spend too much time to talk about what's been occurring, but I'm just going to jump to the proposed cardiac monitoring during peri-COVID era. And here in New York, we went through a period of time since March 13 when the crisis hit us hard, and we were under crunch, and patients were about to start their therapy, their chemotherapy, their ACT or the ACTH, And there was an echo lab that we used here in the community that was shut down during that, right at the beginning of the crisis because of COVID. And we didn't know where to send our patients for echo, and they did not want to go in the city. So it was a bit of a challenge, and it became more of a challenge as the days went on how we were going to monitor our patients. So we sat down as a group, some of the key members within cardiology and some of us breast cancer docs, and tried to come up with something that's sensible, but without deviating too much from the standard. So I'm going to show you what we have proposed at MSK for us, and certainly please feel free to chime in because this is something that we thought it was sensible. It's not bylaws or anything. But so for patients at risk for developing cardiotoxicity, high risk patients, and the language is very similar to what you, Dan and Sarah had put into ASCO, those who had prior cardiotoxic chemotherapy, cardiomyopathy, abnormal EF, coronary disease, prior infarct, etc. Those are high risk patients. That makes sense. Those who've had arrhythmias, moderate severe valvular disease, 2 or more cardiovascular risk factors, older age, low risk, those who didn't meet the above criteria. So we just made it simple. You're high risk or you're low risk. And then we started to go back and review the data. Well, patients getting anthracycline, like an ACT or ACTH, ACTHV, they should get their echo. And we typically have been doing our echo within like a month of starting therapy. But if we can't, because we have nowhere to send patients to, what do we do? If they had one 6 months prior, we'll use it. But most of them wouldn't have had an echo prior because they would not have had a reason to have had it. So we really try to get that echo in, and we will accept an echo that's as old as 6 months prior. We thought that was sufficient. For low risk patients, meaning those without the cardiovascular risk factors, if it is not possible to get an echo MUGA and the patient has no clinical signs of cardiac disease, and they just need to get started on the cancer therapy because it's been sufficient time since their surgery that if we wait too long, their cancer outcome would be compromised. For example, patients with triple negative breast cancer need to start on their cancer therapy within 4 weeks from their surgery. Otherwise, their recurrence rates go up. So in those patients, we try to get that echo in, but if we can't, we just start therapy, and we'll just try to get that echo at some point as they start therapy. And that's really not what we prefer to do, but this is a judgment when we're sort of at a crossroad where the patient just has to start the therapy before their cancer outcomes are compromised. So that's sort of the language here. How do you feel about that, Dan? I mean, you're a cardiologist. I mean, we had to make these decisions thoughtfully.
Yeah, so we proposed a COVID adjusted monitoring strategy for cardiac issues during cancer therapy. And we spent several months actually trying to, actually probably about 2 months trying to kind of get our heads around all these issues. And fortunately, we were notified this week actually that statement will be published in CA Journal for Clinicians. So good. But bottom line is that because of the issues with doing echoes and potentially exposing either a provider or the patient to COVID, we developed a strategy that minimized imaging as part of the equation. I would still say that because echo is available, generally speaking, pretty much everywhere that there's cardiology, that echo is still the preferred test. But the of course, MRI or a MUGA, would be an option in terms of getting an EF screening test. Now, I personally can't stand MUGAs, and I really wouldn't order one ever in my lifetime, I don't think. But nonetheless, those are adequate tests for measurement of EF. But so the question is how important is that? And what we proposed as part of our group was that you could switch to largely a biomarker-based strategy, because the negative predictive value of biomarkers in the normal range is extremely high. So if you do a baseline blood sampling for your patient that you're about to give chemo to, they're definitely going to get blood tests. You know, they're going to go and make sure their CBC is acceptable and their electrolytes, etc. So in order to, you know, get an adequate screen for any evidence of heart failure, if you did a biomarker measurement, an NT-proBNP, for example, and it was normal, then there's really no chance that that person has heart failure at baseline. And then as you go through your treatment, unless they develop symptoms of heart failure, you can really guide your monitoring strategy based on biomarkers. So that's actually what we recommended.
Okay, that's very interesting. That's good to know. You know, because we haven't really found a way to do that correctly. But that's good to know, because we do worry about echo monitoring, you know, patients getting so close with the technician, and have also put in the language that MUGA is also an option, although it's not our preferred regular testing, but it's an option to minimize the exposure. So that's baseline for anthracycline like AC or ACTH, etc. And for an ACTHP, meaning they need serial monitoring, for the low risk, low cardiovascular risk, they get their baseline EF, and then as they go on to their trastuzumab, they should get another one within 6 months. Meaning, what that really means is that they get their EF baseline, and then post AC, if they can't get that EF done because of challenges, we don't want to stop their cancer therapy from proceeding. We have seen that the rate of asymptomatic EF decline is somewhere between 0 to 6% post AC, but not heart failure. So we made that allowance that if they need to keep going, then keep going. Go onward with your THP, but try to squeeze in that next EF within some period of time, meaning 6 to 12 months. What that really means is that somewhere in the middle of your THP, get another one in. That's for your low risk patients with supposedly healthy cardiovascular risk baseline. But the high risk patients, we want them to get that repeat monitoring closer, like within 3 months, meaning try to get it closer to the beginning of your anti-HER2. So we try to be very careful in the language, not to be prescriptive, but also to be lenient enough so that patients can go on and get their therapy. And what do you think about this, Dan? I mean, it's sort of loose language here.
I mean, I think you're trying to do your best to you know, adapt to a challenging situation. So, you know, it all depends. It all depends on your, you know, your comfort level, et cetera. But, you know, in terms of adjustments that you're making to monitoring, I mean, I think those are reasonable. Those are kind of your best, you know, your best guess for how to deal with it. But I would also say that, you know, if MRI is available, then you can actually do an EF measurement and new technology strain measurement for MRI for in really less than 15 minutes. So the amount of exposure for a patient is very minimal, and it's even less time than a MUGA would take. But again, MRI is not available at every place, so that's a limitation.
Right, and certainly, in poor countries, definitely.
I would favor, you know, especially in if we're truly in a pandemic environment, that going away from imaging to a biomarker-based strategy to establish cardiac safety seems like a logical thing to me.
Right. It's making more sense to do it that way, you know, because we talked about it for a decade. How do we embed biomarkers, and do they correlate, or how do we use it if we're already doing imaging? But I think now we're trying to get away from imaging, especially, and I could just sort of expand on this, you know, with subcutaneous trastuzumab, pertuzumab recently approved by the FDA, meaning they can get it We're gonna even doing a trial to do it home base, meaning get it at home, don't come to the clinic, get it. Wouldn't it be lovely that we don't have to make them come in to do an echo just because they're getting their trastuzumab or pertuzumab, but they just get their bloods to monitor. Perhaps the way of the future, Dan. So this is for.
I think the main point is, so depending on what study you're thinking about or what series of studies you're thinking about, you think, oh, okay, well, we did this study where we compared detailed imaging to a biomarker, and detailed imaging may have been a little better than a biomarker based on study A, B, C, or D, whichever study you're thinking about. I wouldn't argue with that necessarily for the detection of significant LV dysfunction. But the point here is that you're establishing cardiac safety with a very sensitive tool that does not expose the patient. And if you have normal biomarkers throughout chemo, you do not have heart failure. I can tell you that for sure.
Right.
So if a patient is generally low risk and they have normal biomarkers, and you go ahead about with your treatment, and then periodically measure biomarkers as you're doing your oncology safety labs, then you're screening for cardiac dysfunction very carefully. And as long as it remains negative, then you don't have to do anything more. I mean, that's our contention.
Right. That seems to make a lot of sense now, in this time period where we don't want to bring patients in for extra testing if they're getting bloods already. But thank you for that. Yeah, because we didn't think about it in our we didn't think about it in our guidelines. We just were not there, but it certainly makes a lot of sense to start embedding it in, so even in trial setting, doing trials, like you say, low risk patients who are going to be at low risk for cardiac events already. Can we just forego imaging? If you want to do one imaging at baseline, that's enough, and you go forward with biomarkers versus the standard arm would be imaging serially and see.
Yeah, I think to me that seems like a very sensible way to proceed, and I agree. Your original contention several years ago was that you're doing too much imaging. The FDA just picked every 3 months because that mirrored the trials that were previously done. There was no data that said, you have to do it every 3 months. They just picked those numbers.
Right. Well, we what that led us to do, that contention led us to do is we're doing a less monitoring trial right now just to show it in a trial setting to move forward. But I think we're getting there. I think we're all trying to get there. Let me just try to finish in here. So for baseline testing for like a TH regimen, basically, remember, these patients do so well. The heart failure rate is 0.5% or less, and asymptomatic decline was less than 3%. So they do so well. So for patients with low risk, they just have no cardiovascular risk factor and they're getting a TH regimen, do we really need to do an echo or MAGA? We are still supposed to, but here we stay here. If it's not feasible in a timely manner because of issues during COVID, go forward with your cancer therapy. Just go forward with cancer therapy. In high-risk patients, meaning those with cardiovascular risk factor, go forward with your cancer therapy. Go forward with TH, but try to get that one echo or MAGA in as soon as you can. At least try to baseline somewhere in the beginning. And then as far as during therapy, what do you do? So when they're on the ACTHP regimen, still try to do your every 3 month monitoring. But if you can't, because of challenges, extend it to 4 months. And this is not really deviating from the standard, because in the trials, we allow patients to have plus minus 3 to 4 weeks to get their echo in. So we didn't deviate that much. And for a non-anthracycline regimen, like a TH regimen, during therapy, we actually said it's okay, do it less. Instead of every 3 months, every 6 months. That's basically based on trial evidence, noting that the heart failure rates were so low, 0.5%. So here we felt relaxed, that they could just do it every 6 months. And if they couldn't do it, then that's up to the physician's discretion, but try to repeat every 6 months. Um, so that's that. And I'm just now up to like 10 minutes. I'll just spend 5 minutes. This case, simple case, a young lady, left lumpectomy, 1.2 centimeter, ER positive, HER2 positive. She's healthy. She has no CV risk factor. Her exam is normal. Her vitals are normal. Simple case, stage 1 breast cancer, gets TH. That's basically it. She was recommended TH. And is she considered low risk, high risk? Then we say she's low risk. And our plan is to obtain an echo or MUGA before starting. But if she's unable to get it and it's time to start, are you comfortable to start? Personally, as an oncologist, I would be. And Dan, as a cardiologist, would you be comfortable in this patient for us to start therapy?
100%, and especially
Great.
if I checked their lipid panel and got an NT-proBNP and they were okay, then I would be good.
You would be okay.
Absolutely.
Good. During therapy, we would try to do her monitoring every 6 months. I'm going to go out on a limb here. What if we don't monitor? How would you feel, Dan?
I would, like I said, I would transition to biomarker-based strategies.
Gotcha.
So maybe every 3 months or so, unless she develops symptoms, that every 3 months or so, I would just check an NT-proBNP, and if it was normal, she's good to go.
Gotcha. So you would monitor differently then. You would do it differently with biomarkers. Gotcha. Okay. That makes sense. I mean, instead of doing nothing, you would attempt to do some blood biomarker. Okay. Thank you. Case number 2 is a 55-year-old mastectomy, bad cancer, 3.2 centimeter, ER negative, HER2 positive with 4 nodes. So lots of nodes. So her risk of breast cancer recurrence is extremely high. It's like over 60% and mortality is high, but she's healthy. She has no CV risk factors. So we are recommending her the full package, AC followed by taxane, trastuzumab, pertuzumab, because we saw in the Affinity trial that dual antibody therapy was beneficial in improving disease-free survival. She has a good EF of 65%, so we got to baseline it. So is she considered at risk for cardiotoxicity based on ASCO guidelines? The answer is yes, because she's getting a double hit regimen. She's getting an anthracycline and she's getting anti-HER2. During treatment, ideally, she would be monitored every 3 months. But if she's unable to get monitoring, what is the acceptable interval? At Memorial, we try to stay within standard. We said, okay, you can go out as far as 4.5 months, and that's just being cautious. But I'm just curious, Dan. I mean, as a cardiologist, would you just stop monitoring a person like her and just do biomarkers only? What is your comfort level there?
Yeah, I mean, this is a different story than your first one, but these patients are getting hit with a kitchen sink, so they got every single thing in the kitchen sink is going in, and that's, if I had breast cancer at that degree, I'd say give me both kitchen sinks, and of course you want to get rid of the cancer, that's your goal. So I would be very fastidious about ascertaining and detecting any cardiovascular risk factors. And so I would contend that in this patient, at many points along the way, she may become hypertensive. She probably has hyperlipidemia that's never been checked. I would also periodically follow biomarkers, and once you see biomarkers start to bump up, then you know you need to be more definitive. But I would look for excuses to give this patient carvedilol or an ACE or ARB. And I would watch this patient very closely, but I'm not sure I would do imaging in doing it.
So can I ask you, for a person like her who's 55, bad cancer, no known CV risk factor, good EF at baseline, should I be sending her to cardiology at baseline just to get blessed? She looks 100%. Good, her numbers look good. Should I send her to cardiology to get blessed before she goes forward?
That's what I would vote for, but you're an oncologist, you decide what you do. But
sure. I think
this is a situation where I think that person would benefit from preventive therapy
Got it.
because she's going to get very intense chemo for sure.
Yes. Yeah.
And so I would want to start that medication a priori. If I couldn't find a cardiovascular risk factor, if I just look closer, probably I'll find one. So.
Right. So in the world of COVID and virtual visits, maybe sending her to cardiology for a virtual visit, and she can get her vitals. I mean, are there ways to do vitals without coming to the clinic?
Yeah. I mean, that's what we do that. We do that stuff all the time. And I think that, if as an oncologist, you're in there talking to the patient and you talk about all the details about how big the cancer is and the lymph nodes and the different markers, and you spend an hour talking about all that stuff. You're not going to then spend the next 20 minutes talking about salt restriction and monitoring your blood pressure and all this kind of stuff, right? I mean, you're not going to do that.
Right. No.
So that's where a cardiologist, a cardio-oncologist in particular, could really spend the time to say, this is important. We want to prevent this problem from happening, and this is how we do it. We do it this way. You weigh yourself every day, you check your blood pressure and your heart rate, so on and so forth.
So on that note, I'm going to end, but I'm going to say something about what you said, Dan. I so appreciate it. The bottom line, risk of heart failure, it's there with non-anthracycline NO2 less than 1%, with an ACTH-like regimen is upwards of 4, anthracycline 1 to 3. Guidelines are in place. We talked about them, FDA, NCC, and ASCO. But during the peri-COVID era, basically, this is a summary of what we just went through. Do the best you can, the bottom line. Do the best you can. Monitor at baseline. Do it serially if you can. But be mindful that, the cancer is there, that we've got to treat the cancer. But what I want to end with, Dan, is that you've made me think further that instead of trying to suffer in silence and trying to do the best we can to take care of our patients as oncologists virtually, that we will have partners, cardiology colleagues who can help us take care of them virtually. I just thought of that, Dan. Thank you. Basically, consult with you guys, and you can help us. If they can't get their echo imaging, you can help us.
Honestly, Chau, I met you a decade ago, and I'm sure that I have said something along this line in the past. So, and you have been very proactive in general. So I think that, you are a great example of, and the fact that you're even giving this presentation is amazing. So I think that, we appreciate all of what you're doing, and what we really want to do is help. We want to help. We don't want to hit you over the head to say you needed to do this echo every 2 months or every 6 days or whatever we say. We don't want to say those things. We want to say, how can we help get this patient through their treatment? That's it. You do the best that you can do from a cancer point of view, and we want to do the best that we can do.
Right. No, this is really wonderful. I think that we're going forward in this new world. We're having to all turn left together, but we don't have to turn left by ourselves, that we will walk hand by hand.
Absolutely.
Yes.
There is a question from another participant, Dan Gilon from Israel. He's wondering about the role of strain testing for breast monitoring.
So Dan, you're on.
Yeah, no, I think where you can obtain it, I think it's, and if it can be obtained in an accurate and effective way, there's some technical limitations there. But I definitely feel that strain is a more sensitive measure of cardiac function. But by the same token, to do a really detailed strain measurement by echo requires additional time and expertise. So whatever limitations you have in terms of imaging, because of COVID and that type of thing, then, you're not going to be able to do strain in that setting, or you won't be able to do it as easily. But I do think that where available and when feasible, it is probably a a better or a more sensitive measure of cardiac function for sure.
Mhm. Other questions, Steve? We're up to the hour.
I have a quick question, Dr. Dane. This is Chris Fine, one of the third-year fellows at the University of Louisville. In what breast cancer population do you typically anticipate a higher dose anthracycline up front? I'm trying to get a general sense of anticipatory care for the patients, and that could be something really valuable to a cardio-oncologist.
Okay. In the modern era, no one that I can think of, like early stage breast cancer, if they're getting anthracycline, it's upwards of 240 of doxorubicin. The older regimen was upwards of 300, but not necessary anymore because that was when we gave CAF, meaning anthracycline only. Now we give AC and then T. So we don't have to give higher dosing of anthracycline. And when they're getting anti-HER2, you really don't have to give higher dosing. But as far as the metastatic patients, in the older times, we didn't have multiple chemos. So we would just increase their cumulative exposure. But now we have so many chemos for metastatic, I can't think of a patient that I need to give higher dosing of anthracycline cumulatively. I can't think of one.
The main place where that might occur would be somebody who is a cancer survivor from like lymphoma, previously got anthracycline, and now they have triple negative disease. That might be a situation where you would.
Yep, that might be. You're right. You're absolutely right. And it's so rare. That's just so rare. It's yeah, maybe. Yes.
Oh, yeah, I'm sorry.
Or I mean, we use like taxane-based treatment. We can go in circles, talk about taxane-based anthracycline, but so on. But it's a rare situation.
Very helpful. Thank you.
Other questions? Thank you. Okay.
Oh, sounds like you got all the way through the hour, Chau. Very good.
I got through the hour. Thank you, Dan, for participating. You made it so lively. I so appreciate your cardiology input. I think we're both on the same page. We're trying to do the best we can and
Absolutely.
monitor sensibly, not overdoing, but certainly not ignoring. Still trying to monitor, but it's nice to hear your voice and know that we can have our cardiology colleagues help us virtually.
Absolutely. Well, ideally we wouldn't want it to be virtual, but on the other hand, I'm sure that you've had your fill of Zoom meetings, and
yes.
Frequently talking to your computer is a little bit less than satisfactory. So
yes,
try to spice it up.
Yes. Thank you. Thank you. Okay, we're up to the hour, Steve. I think folks have to go to work.
Yeah, thank you very, very much. Excellent. Thanks, Dan,
Thank you.
as well.
Thank you.
All right. Thanks a lot, Chau. Take care.
Thanks so much. Have a great day. Bye-bye. Bye-bye.
Okay, bye-bye.
Bye-bye.